President and CEO of BioVentures for Global Health, and moderating this session on innovation and collaboration in the time of COVID-19 and accelerating research and development to save lives. We've brought together a really excellent group of panelists that are representing different sectors, different regions, both on the continent and internationally, who are working in partnership to address the pandemic in Africa. And so I will introduce our panelists and then we'll jump into the recorded sessions. We hope to have some time for Q&A after the session, but perhaps if we are running short on time, people could send their questions in a chat box, and I'd be happy to direct those directly to the panelists who can respond directly. So I'm very pleased to have Dr. Shola Odusanya, the center leader of the Pan-African Materials Institute. He will be speaking about how his institute is working in collaboration to activate local capabilities to fill the needs of Nigeria during this pandemic, using engineering and technology and 3D printers. Also, we have Professor Wole Soboyejo, the Provost of Worcester Polytechnic Institute. Professor Wole and Dr. Shola are collaborating together on their work, and Prof. Wole is building partnerships and innovation, driving innovation on the continent to respond specifically to the pandemic. And we'll hear about how their partnership has formed a foundation to respond very quickly in driving innovation for COVID-19. We also have Dr. Freddy Nguyen, the co-director of the MIT COVID-19 Challenge and Research Fellow at the MIT Innovation Initiative. Freddy has led the hackathons out of MIT, and specifically a hackathon that focused on catalyzing Africa-centric solutions for the pandemic. We have Ms. Noella Bigirimana from the Rwanda Biomedical Centre, who is playing a special role in addressing the pandemic in Rwanda under the Ministry of Health. Noella will speak about harnessing Rwanda's innovation and leadership and describe how the country is responding to COVID-19. We have Magda Schoenich, who is the head of the Center for Scientific Leadership and Innovation of R&D at Takeda. Magda will speak about some of the big picture programs leveraging innovation and innovative thinking in tackling global health, including problems around COVID-19 and the pandemic we're facing. And then we have Professor Martins Emiji, the head of the Advanced Biology and Chemistry Laboratories at the National Institute for Pharmaceutical Research and Development in Abuja, Nigeria. Martins will be speaking about investing in Nigeria's natural products to help fight COVID-19 by strengthening the immune system. So thank you everyone for joining. I think everyone will agree we have a fantastic group of panelists representing different sectors and different innovative approaches to tackling this pandemic. So we can start with the video presentations now. Hello, my name is Jennifer Dent. I'm the President and CEO of BioVentures for Global Health, or BVGH, and it's my pleasure to introduce the Innovation and Collaboration in the Time of COVID-19, Accelerating Research and Development to Save Lives panel. While no corner of the world has remained untouched by COVID-19, battling the pandemic is particularly challenging in low-resource settings, which face many African countries. In this session, we'll learn how African countries are leveraging local and global partnerships and technology and expertise to to fight COVID-19. We'll hear about a Nigerian-American partnership that's using 3D printers to scale up personal protective equipment, PPE, production for African healthcare workers. We'll meet leaders, one from a multinational pharmaceutical company and one from a global engineering powerhouse, MIT, who are spearheading initiatives to catalyze innovative Africa-centric solutions to the pandemic. We'll also listen to a scientist from the Rwandan Ministry of Health discuss her government's technology-driven response to COVID-19, a response that's recognized around the world and not a surprise coming from Rwanda's government and leadership. And lastly, we'll hear from a Nigerian professor at NIPRID who's driving natural product discovery to see how Nigeria can leverage its own natural resources to boost the response to COVID-19. It's my pleasure to introduce our speakers, Dr. Shola Odusanya, the center leader of the Pan-African Materials Institute, Professor Wole Soboyejo, Provost of Worcester Polytechnic Institute in Massachusetts, Dr. Freddy Nguyen, co-director of the MIT COVID-19 Challenge and research fellow of the MIT Innovation Initiative, Ms. Noella Bigirimana, Rwanda Special Advisor to the Rwanda Biomedical Centre and Ministry of Health, Ms. Magda Shonich, Head of the Center for Scientific Leadership and Innovation at R&D at Takeda Pharmaceuticals, and Professor Martins Amiji, Head of Advanced Biology Chemistry Laboratories at the National Institute for Pharmaceutical Research and Development, or NIPRID, in Abuja. Welcome.
Thank you for having me. It is an absolute pleasure to be joining this conference today and this panel for the day. And I am Noella Bigirimana. I'm a strategic advisor at the Rwanda Biomedical Centre. We are an agency under the Ministry of Health in Rwanda, and we are currently coordinating the COVID-19 response in the country. It's my pleasure today to be discussing how we have been able to leverage technology, how we have been able to leverage innovation, and ways we've done that through partnership, which has been quite important. And so perhaps to set the stage, I want to maybe share a little bit of how the COVID-19 response is structured in the country. And so far in Rwanda, perhaps I can start with the situation. We have a little over 2,500 cases, and we have been able to have half of them already they've already been treated and they have recovered fully, and the other half, or a little bit around 900 people, are currently in treatment centers. And so we've unfortunately had 10 deaths. And so what we've seen is that so far the situation has been sporadic cases, and in some places in the country, like in the capital city, you'll have places that have clusters of cases. And so with that in mind, in terms of epidemiological situation, I wanted to go over how we've been able to structure this response in Rwanda. The response in Rwanda, the preparedness for SARS-CoV-2, fighting the SARS-CoV-2 virus started early. It started back in January, when it became clear that this virus that was spreading widely across countries was going to perhaps have the potential to be a crisis. And so back in January, we were doing a screening at the ports of entry or points of entry, and including the Kigali International Airport, where we had teams that were looking at travelers and passengers coming through. And so the way we structured this response is that a national steering committee was put in place. And this national steering committee has the highest level of officers in the committee and meets very regularly. And so we also have a national task force, And the National Task Force, and I'm a member of the task force, has been multi-sectoral, has put together institutions. We've had partners join us in the National Task Force, and it's really sort of the command post for the national response to COVID in Rwanda. But I wanted to highlight two key elements in our coordination and planning that helped in everything that we do. One of these structures is the Science Advisory Group. The Science Advisory Group has experts in many different areas. In epidemic response, we have a lot of experts in the group, and we also have partners like the World Health Organization, the CDC, and many different partners and that have been able to join us in ensuring that we're putting evidence at the forefront for our response and for our policy making. Any decision that's taken really has gone through and has been influenced by the evidence that we're seeing. So this Science Advisory Group has been key. Another part that has been key has been partners engagement and coordination. It has been quite important to be able, not only when it comes to managing the response and the various pillars of the response, but I'll come back to it. On how important it's been. And as I mentioned, there were early and decisive measures that were taken and allowed us to control this disease early on. I've mentioned the structure at the national level, but it's quite important to know that decentralization and integration have been key. You have to have a response at the provincial level. We've had responses also organized at the district level, up to the community level. And that has been done through leveraging existing systems and being able to really have these comprehensive tasks and measures taken. And another part has been ensuring the continuity of healthcare services. And that is key. As much as we are addressing this healthcare crisis case, it's been quite important to maintain the other programs, the other national programs, ensure that we are delivering for the citizens of Rwanda and that we're maintaining quality care and maintaining outcomes. So we avoid losing ground on many of the other diseases. And a part that I wanted to highlight again is that we've been able to leverage research, innovation, and knowledge sharing as key pillars in all that we do. So we've done a lot of publications. We are part of forums like this one, not only to share what we're doing, but also to hear about what other countries are doing. Now, I wanted to take this moment and truly look at, perhaps give a few examples on the innovative approaches that we've used. I will highlight a few, they're not the only ones, but as I go through, I'll share how we've come to have this as part of our pillars in the response. When it comes to contact tracing, again, as you know, finding and tracing, finding cases and tracing contacts is quite important. We find that paperless open data kits or ODKs application have been key. So we have teams that are using mobile devices to be able to register these information, and then you're able to have real-time information of where the contacts are, where the cases are. And that is very important when it comes to decision-making and tailoring the response. And I'll keep mentioning the tailoring of responses because the country, the region, or the continent, or globally, the situation is not homogeneous, right? You'll have different approaches for different parts of a country or a region. In terms of testing, what we've done is some of the approaches that we've used and leverage our pooled testing in a country like ours, where there's where we've seen sporadic cases or a few clusters of cases. We're able to do the pooling not only to expand the capacity, right? When we started, we could only do, when you started early on in February to test for SARS-CoV-2, we were only able to do approximately 300 tests a day. We were able to run 300 samples a day. Now we've gone beyond that, and we do an average of 5,000 And we keep increasing, and pool testing has been key in this process. And so we also have samples that are tracked real time, and the results that are sent by SMS and email. And the intention here is that this testing and these results impact directly the people, and sometimes impact directly their care, their travels, or just their behaviors. And so that has been also a big part of what we do. When it comes to surveillance at the healthcare facility level, we've heavily leveraged the EIDSR being this digital reporting surveillance system, and it works as an early warning for will highlight any suspect COVID-19 cases. And so we're able to monitor the diseases that way. We have sentinel surveillance across all the provinces in the country. Another strategy that we've used and we keep using frequently is the drive-through strategy. For example, in Kigali, what we've focused on has been through, when it comes to the drive-through, is a random sampling. How is the situation in a city like Kigali? So you go to places of high traffic, of pedestrians, of cars, people on motorcycles. You also go on the outskirts of Kigali because that's where you find people coming in and out of the city. And that tells us, or gives us, a picture of what the situation is when it comes to COVID. And so we run a drive-through testing 1 or 2 times each month. And another approach that I wanted to highlight is in terms of IPC, infection prevention control. As you know, SARS-CoV-2 can be transmitted in many different ways. And it's quite important to reduce the contact between people, and the use of robot has proven to be a good way to have these IPC measures in place. And so we've used robots as not only an innovative way or a way of leveraging technology to carry out temperature checking, to carry out monitoring of patients, and to do event room delivery. And another impact or another benefit is also that you are able to work more efficiently with the staff that is there when you also have robots that are doing these other tasks. We haven't just used the robots in the healthcare setting, we've actually used them at the airport as well. As you know, Rwanda has reopened commercial flights. As of August 1st, we are receiving travelers from across the world. And so one of the first screenings or healthcare screening at the airport is done by the robots that are able to look for early warning signs of COVID-19 and do this mass screening. And there's also studies are ongoing, including in my institution, the Rwanda Biomedical Centre, where we are currently looking at disinfection gates that are made in Rwanda and to be able to validate them. And one other part that I wanted to mention is, in terms of innovative approaches, is in data visualization. So what's happening is, as you are doing the surveillance, as you're doing the testing, as you're doing the contact tracing, you end up with a lot of data. And so you have to be able to visualize this data so that you can infer what's happening, or you can even predict. And ultimately, you are able to tailor the measures for different parts of the country. I'm sitting here in Kigali, and I'm able to see from the dashboards that we have in our offices where the most cases are. And so what you can infer are trends. And you look closely, and you're able to also have access to dashboards that are for outside the city. So I can see what the situation is in the western part, in the eastern part, northern and southern parts of the country. And these have been key. When we use technologies like geographic information system, we're able to leverage GIS and monitor COVID cases down to the household level. And you start to find some interesting dynamics of infections, and you're able to for the infections, you're able to respond quickly to the population and the population need of that area. And this has made a huge difference in the way we approach COVID-19 parts. And so everything that we have done has been in close partnership with collaborators. And it's been quite important, as I mentioned early on, not only to maintain the kind of healthcare services that we're providing, but also to shift a focus towards addressing this, because COVID-19 really has put pressure across, and that's true for many countries in the world, pressure across the healthcare system. So being able to leverage partnerships and partners are in place has been key and has been quite important. An example that I'll provide is that measures for COVID-19, which in some ways put at risk other programs, when you work closely with a partner, you're able to adjust. You're able to adjust not only the way we run this program, but also the resources and the resource allocation. At this moment, it's really tough to define what the future of this pandemic looks like. We don't know. We are still at a learning phase, but what we do know is that we'll keep looking for any clusters of cases, we'll keep looking at the prevention, and we'll also keep working closely with our partners to not only, again, maintain the healthcare services that we're offering, but being able to build a system that's resilient. Right now we're dealing with COVID-19. We don't know what's coming. We have, for example, been able to leverage some of our experience from the Ebola crisis that happened in some of our neighboring countries. We didn't have any Ebola cases because we were putting in place a robust healthcare system with these key pillars that are in place. And so, again, we don't know what the future of this pandemic will be like, but I think what I would say confidently is that we're ready, we're adapting. As I speak right now, we are in the middle, the Rwanda Biomedical Centre is doing another drive-through assessment or survey. We were in Kigali today, and we are gonna be, we've tested, I think, more than 300 people just today, just to get an idea of, at random, in the city, high traffic areas, to get an idea of, again, what the situation is like, if there's anything that's evolving and how to address it. So I'm gonna stop here. I'm really excited to be part of this panel, and I look forward to hearing from the other panelists, and I look forward to answering your question in the Q&A. Thank you.
So today I'm going to talk about bioinnovation for COVID-19 management in Africa. I'm Wole Soboyejo. Now, the efforts that we have in collaborating with various scientists and innovators in Africa really started around the mid-1990s, when I started thinking about ways of connecting to African scientists and technologists. This was facilitated by a workshop that was held in Pretoria in 2000 at the Farm Inn, where scientists from all over Africa and engineers came together with US collaborators to discuss ways in which we can collaborate in science and technology. This led eventually to the establishment of various collaborations that have persisted until now. And so we're in the 20th year of this US-Africa collaboration. At this meeting in Pretoria, the group of us that came together decided that we wanted to focus on science using a systems-based interdisciplinary approach to address global challenges of health, water, energy, and sustainable housing. And the idea was to bring people from different disciplines to innovate and to also promote exchanges between the US and Africa to develop new innovations that address global challenges. What came out of that was a number of exchange visits over a period of about 6 years, where scientists from Africa came to the US to work with us in our labs, the collaborators. At that time, I was at Princeton University, and these are some of the folks that came. Grace Oyatobu, top left, came from Obafemi Awolowo University. Tom Otiti, top right, came from Makerere University. And we had a number of scientists over time, 100 fellows that visited, who took their skills back to Africa to develop Africa. We also sent US students to Africa who came back totally transformed by the experience of working in Africa. The other thing that came out was the so-called Nelson Mandela institutions. These are centers of excellence in science and technology. One of these is in Arusha, Tanzania, which focuses on the life sciences. Another one in Burkina Faso, which focuses on water and the environment. And one of these is in Abuja, which was an institution that I was asked to lead, which focuses on energy and materials. So those institutions went from ideas to reality in a few years, thanks to the support of African leaders such as President Obasanjo in Nigeria and President Jakaya Kikwete in Tanzania. And this is the campus of the African University of Science and Technology, which was an institution that was built as a result of the collaborations that we had with the leaders in Nigeria, and really who put forth 240 hectares of land and $40 million to create this. Here are some of the graduates of this institution, and this just shows you the driveway into one of Africa's best places for training really bright people, irrespective of their ability to pay. We also built a culture of research at the AUST, which I was privileged to serve as president, where we started having centers of excellence funded. One of these was the World Bank African Centers of Excellence that received $8 million to address the challenging problems that I described earlier. Now, since moving to WPI in 2016, what we have tried to do is to build on the era of the fourth industrial revolution and really leverage new technologies in robotics for manufacturing or for medical robotics, and new advances in autonomous vehicles as opportunities for Africa. And so what we're trying to do is to connect those interests with innovation in Africa. And most recently, we've had the opportunity of taking the advances in 3D printing, medical robotics, and design to really work as a community to address the COVID-19 challenges. So when COVID-19 struck in the US, we started designing and making face shields, nose covers. And I realized that by connecting to the same Africa network, we could transfer those skills and co-create the solutions that are needed to address those needs in an African context. And so we started working with the African University of Science and Technology in refining our original designs to meet the needs of Africa. We organized a training session for about 25 African universities, who then started innovating with the brackets for the face shields. And in the case of the folks at the AUST, they were able to innovate and start working also on the development of N95 nose covers, which they also 3D printed and started to make, and then integrated with the filters that are needed to make them successful. These were then delivered to the National Hospital in Abuja, who have tested these and are now using them in their hospital services as part of their way of addressing the COVID-19 challenges. And beyond that, we started also looking at ventilators and alternatives to standard ventilators that are expensive. What we found was that these expensive ventilators are not in adequate supply to deal with the COVID needs. And so we started really looking at how we go beyond these relatively expensive ventilators to the design of resuscitators that are based on the bag valve mask, the BVM or ambu bag. And so by working with our engineers here at WPI and collaborators in Africa, we were basically able to introduce into the bag valve mask filters that filter out possible coronavirus, and innovations in the design that could create ventilators that can basically provide much needed oxygen and ventilation and resuscitation to patients. So what we came up with was a design that was simple, with a viral filter and a CO2 sensor, and something that can be assembled and reverse engineered in various ways. By again working online with 24 or 25 sites across Africa, we shared this with other innovators in Africa. And we also created a context where this could then be tested in hospitals and refined for the local needs. And so this just shows you then an intermediate design for a resuscitator that can be used for emergency needs in ways that fill a gap between the ventilators on the one hand, which are very expensive, and many scenarios where people need to ventilate or resuscitate the lungs. We're now working with those 24 sites to deliver these to local hospital, just as we did with the PPE supplies. Now, most recently, we've also worked on a project that uses ultrasound to detect the onset of COVID-19. This is work that's been done by Kai Zhang here at WPI. And what we've done is to link this diagnostic testing with our team in Abuja. And so this is just shows you the system that we've been co-creating with the team in Abuja, which is a medical robotic lung ultrasound system that can scan the lungs and detect the signals that are associated with the onset of COVID-19. We're now working with the group in Abuja to test these systems out in patients at the National Hospital in Abuja. And the goal is to now deploy this as an example of the co-creation of medical robotics capabilities that address the COVID-19 needs in an African setting. This project was recently supported by a grant from the National Institutes of Health, and we're hoping to share this with other countries in other hospitals in Africa. So just in a space of a few months, we've gone from ideation in medical robotics to now a situation where we're beginning to ship the systems out and begin the tests, going through the proper ethical clinical approvals in a way that's consistent with the best of global practices. So I hope that this talk shows the value of the collaboration and the co-creation of solutions, working in partnership with African scientists and technologists and innovators. This outcome that we have in the COVID era was built on relationships that were established over time. And so I'd like to encourage those that have an interest in working with African innovators to invest in those efforts to build the relationships that make the innovation possible. And really, when we started introducing folks to robotics, we did this in programs that really were just to excite people about robotics and 3D printing. But today, that now has created the technologies that are needed in the hospitals, in the homes, for 3D printing of face shields and nose covers, and the co-creation of solutions using feedback from African contexts that inform the designs. What we're now doing is building on that and working with local industry to expand the production capacity. We're also building the engineering capacity to design new solutions for resuscitators that add to the capabilities that are needed to ventilate the lungs in African contexts. And we're doing this again with African universities. And in the next few months, we're shipping a number of these ventilators, resuscitators to those places for further refinement and application in those hospitals. And as the field of robotics expands into medicine, we're not only just applying the products of medical robotics, we're co-creating those solutions with African innovators. And we're working through the ethical processes that are needed to apply these. We really see the opportunity here to leverage the innovation capacity of Africans to create solutions that are really global in their impact, and to obtain the venture capital funding and the industrial collaborations that we need to scale this up. And so we're working on going beyond 3D printing to really injection molding for production of large volumes of PPEs, as well as the engineering of resuscitators and medical robots that can be sold, not just in Africa, but across the world. So with that, we'd like to thank you for inviting us to participate in this forum. And we're excited about the possibilities of collaborating with those with similar goals. Thank you very much.
Hi, my name is Freddy Nguyen. I am a co-director of the MIT COVID-19 Challenge, also a resident physician in the Department of Pathology at Mount Sinai Hospital, and a postdoctoral fellow at MIT. And today gives me great pleasure to share with you some of the work that we've been doing at MIT, especially around the MIT COVID-19 Challenge. The MIT COVID-19 Challenge was launched back in late March, early April, really as a series of virtual hackathons or virtual events. It was around a time where we wanted to find a framework in which to channel a lot of the untapped talent around the world to really target some of the issues that we were facing around COVID-19. We set this initiative up as a series of virtual events, and really what differentiates this from the propensity of other virtual hackathons you may have seen around COVID-19 and pipeline. There's also essentially an equal focus on the hackathon weekend itself, but essentially that pipeline that happens afterwards and how do we best support those teams in the longer term. And the whole point of doing a series of these events is really to make sure that we stay hyper-focused in each virtual hackathon on the most pressing problems at that time in point, really knowing that the problems of today hopefully are not the same problems in a couple months from now, and vice versa, the problems that are that will be pressing in a couple months may not even be on our radar today. So as I mentioned, we kicked off this initiative back in April with the pandemic event. Ultimately, in May, we then did an event focus around Africa. We also did a datathon in mid-May, and that was followed by a second round of Beat the Pandemic towards the end of May. And then in June, we decided to also do an event focus around Latin America as well. So to focus more specifically about the Africa event that took Africa Takes on COVID-19 under the MIT COVID-19 Challenge was on May 1st through the 3rd. And in a very short time span of around 2 weeks, we were able to receive participant applications from nearly 2,350 people, really representing over 100 different countries. Ultimately, we selected about 1,500 participants, 200 mentors, 70 plus partners as part of the Africa Takes on COVID-19. We were extremely pleased to see that we had representation from 44 of the 54 African countries. Over 50% of the participants were from Africa itself. This particular challenge focused into two areas. One was on strengthening the health system, and two was on flattening the curve. In particular, the tracks for the strengthening the health system focused on how to get patient samples to the labs for analysis, how to strengthen referral systems, how to empower the healthcare workforce, how to be better prepared for for potential surges during COVID-19. How to sustain primary care services during COVID-19, how to energize healthcare, in particular the energy infrastructure that was in place. And then on the flattening the curve side, we focused on 4 additional tracks. One was on preventing community transmission, production of essential supplies, especially PPEs, but also other healthcare supplies. Enabling the work and supporting livelihoods, especially in an economy where having people that were locked down or in quarantine would severely affect people's livelihoods. And then lastly, on combating misinformation. So MIT Hacking Medicine was part of the partner organizations underneath this COVID-19 challenge, and really where a lot of the methodology of what we do was developed at. And really what sets us apart is in 4 categories. One is the diversity of the people that we bring to our events, really looking for clinicians, scientists, engineers, patients, user designers, programmers, coders, business, legal, but basically every single stakeholder that you might want to see within the healthcare system. We want to have represented in our participants and our mentors and our judges as part of the event. The second part is the design methodology that we use, where we really encourage participants to solve on real problems that are real needed that are being faced by real people. And we want to empower participants to build solutions around these experiences that they've encountered. The third part is the viability or the feasibility of the idea. So we care more about ensuring that this isn't something that's just created over a weekend and that's it, but it's that these ideas will continue to get developed. But in order for that to be successful, they have to truly understand what is the context in which they're developing the solution? How will the solution get implemented? And what's the feasibility or sustainability of these solutions? And lastly is the community aspect. As much as we would love to have every single idea that was created on these hackathons to continue to succeed, we know, of course, that's not realistic. But we want to create this community of now newly empowered individuals who now know how to approach problem solving within the healthcare space, but also now have a community of people that they can work with to tackle some of these problems, whether it's the problems that they decide to pick on the weekend itself or on the problems that they encounter further down the road. So for us, hacking isn't about gaining unauthorized access or breaking into the system, but it's really a creative application of ingenuity. And unlike most of the typical ways that you think about hackathons, for us at MIT, our hackathons, there's not a need to code. It's highly interdisciplinary. The work is very much problem-centered around real user needs. As I mentioned, the feasibility and the business viability are equally integral. So what does an MIT hackathon look like? Well, our hackathons used to look like this, where we have hundreds of people that were gathered together in the same space. But now in light of COVID-19, we've now gone virtual and our hackathons look like this, a series of course, the Zoom rooms spread across. However, the hackathon process is still fairly much the same, whether compared to our live events. It still occurs over a weekend period, starting off on a Friday evening, going through Saturday and all the way into Sunday. And so what happens on a Friday is that participants get to pitch the problems that they're passionate about, that they want to work on over the weekend. Then we facilitate a mixing type of interactions in which participants get to meet with each other, trying to figure out what are the problems that they want to work on over that time period during the weekend. And then we move into the hacking period, and that's usually starts on the Friday evening and goes all the way until Sunday morning, in which participants develop their ideas as part of problem definition, solution development, doing some of the market landscape research, and then pitching their ideas to the mentors that we have coming in throughout the event. And then we also have mentors that are coming in throughout. As part of the Africa event, we had, I think, over nearly 300 mentors that were available throughout the weekend, really providing subject matter expertise to the participants, but also giving participants feedback from a non-subject matter expertise, meaning can the participants communicate their ideas succinctly and clearly and make the case for the value proposition. And lastly, as part of this feedback and this iteration process continues throughout the weekend, which ends on Sunday afternoon with a 3-minute presentation from all of the teams, followed by 2 minutes of Q&A from the judges. So in summary, the hackathon process really starts with helping participants identify the problem, breaking that problem down to subcomponents, brainstorming the potential solutions around that problem, and continuing in this cycle of iterating and improving. As part of our live events before, MIT had partnered up with Massachusetts General Hospital's Global Health Program and CamTech, or the Consortium for Affordable Medical Technologies. So in live, we've had prior experience in running, the love and global health focused hackathons that brought thousands of people together and have really provided an ecosystem for doing innovation in Uganda. A couple of the ideas that have come out of the live events have been surrounding, for example, an augmented infant resuscitator that was put together, and then also a device that was put on motorcycles for better, for safer way to ride on those motorcycles. And some of these solutions have been able to effectively scale up very nicely over the last few years and have been implemented by larger companies like Philips. But to give you a few of the examples that came out of the MIT COVID-19 challenge itself, we had one team who's called Fast Moving Prevention Education. And as you can see from this slide here, their team, and this is true of virtually almost every single team that was formed as part of the MIT COVID-19 challenge, was that they spread across multiple countries, multiple time zones, really from all over the globe. But this particular team was really focused on the misinformation aspect. And so what they decided to use was to leverage existing fast-moving consumer goods companies such as Coca-Cola or other, where they already had expensive distribution networks already in place. And using those existing networks, the idea was to try and have this information essentially be incorporated right into their products, which you can see here, for example, that you have a can of Coca-Cola and then having the information about how to properly mask up during this time of COVID-19. The second team is called SaniPack. There, the problem they were trying to tackle was really around N95s, which were really meant to be used single point and not really meant for continuous use. But because of the shortage of N95 masks, it wasn't realistic or feasible for us to continue to use N95s in that manner. So there has been a large influx of large-scale PPE disinfection devices that have been developed. But really, SaniPack's goal was to try and develop a portable battery-powered UVC N95 sterilizer. And so they've been spending the last few months developing on this solution. And then lastly, we had a third team called WePool. And really their aspect was on, their problem they were trying to solve was around testing for COVID-19. And really trying to provide a platform for intelligent pooling for effective COVID-19 testing. Right now, the shortage of testing is fairly significant. And so how do we now go from having a single test to a single person? By pooling, we can now use the same test to test multiple people at once. But unfortunately, with pooling, there's some challenges there too, because if everyone in the pool is negative, then great. But if in the whole pool of multiple samples, there's a positive, then we have to go back and individually test them. And so where WePool comes in is really trying to develop some algorithms to better improve who should be pulled together, as opposed to what currently we would do is kind of a random pooling process. And so those are just some of the ideas that have come out. But this last idea is really kind of combining a little bit of the machine learning aspect and artificial intelligence as part of that process. So wanted to really, again, highlight that we could have done any of these events without the large network of partners that have come on board, not just for during the event itself, or also post-event. To work with this team, continue to mentor with these teams, continue to provide them with the resources and opportunities to accelerate their progress as well. So thank you again so much for your time, and look forward to the Q&A.
Okay. My name is Shola Odusanya. I am the co-center leader of the Pan-African Materials Institute. Pan-African Materials Institute was established by the World Bank, funding that was given to African University of Science and Technology in 2014. I'm also director of biotechnology and engineering at the Shedder Science and Technology Complex. AUST is a small campus. It's a postgraduate university. One of the universities that was established in Nigeria with a purpose. Most other universities are established as compensation for communities and service providers for other communities. But AUST was formed to provide critical thinkers that could tackle African problems. So we work around this by developing a problem-solving pedagogy, and we also recruit students from African countries. And one of its driving philosophies is that the lack of money shouldn't be a reason why you shouldn't have good education. We engage leading Africans in diaspora diaspora in teaching, research, and outreach to industry and community in such a way that we turn what would have been brain to brain recirculation. And we develop a bottom-up entrepreneurial approach. At AUST, we have 4 major research programs, as well as a program in pure and applied mathematics. So we do petroleum engineering, material science and engineering, computer science, and theoretical. When the pandemic started, we energized our relationship with WPI. I must mention also that WPI hosts the former president of AUST, Professor Soboyejo, who has been mentoring students and motivating the science and engineering at the material science and engineering department of AUST. The relationship led to us to have an increased network of opportunities by working with world-class faculty and engaging in high-level technology and research and cultural improvements with our activities. The relationship also led to expansion of competencies. We started having opportunities of better imaging capacities, nanotechnology, artificial intelligence, and robotics. And we started a program earlier, actually, called the Maths and Science for Sub-Saharan Africa, where we were exposed to project-based learning. And the relationship also led to research culture and competence improvement. We were able to develop 3D printing materials during the beginning of the COVID pandemic, starting from a conversation where we saw ourselves sequestered in the homes and separated from our equipment. We realized that we could actually do something to help when it became clear that there was a shortage of personal protective equipment for medical practitioners, and were always depending on overseas transport, which became difficult at that stage. We looked at the equipment we have, and at that point, it became clear to us that we had capacity to produce up to 50 face shields per day and up to 15 nose masks per day. With the efforts that we have made so far and the interactions we have had with hospitals, it became clear that we needed to have more of this equipment and to further energize us to work more with healthcare practitioners and improve the degree of things that we do. We now wrote for a project that allowed us to do a research with hospital workers that would enable us to test our PPEs. We are still in that testing and consultation phase, and we have received from our internal review board approval for us to go for that. So we're able to, after that process, deliver 85 face shields to National Hospital in Abuja. We also gave 10 N95 nose masks, and we used engineering methods to test this, and we concluded that these were sufficient for the hospital workers based on the feedback we obtained from them. They also gave us ideas on what the test kits that we gave them look like and what improvements we could make. So we also went further to give face shields to some doctors in Kano State. The relationship was so nice that the Nigeria Air Force assisted us in doing the transport when there was a total lockdown between Abuja and Kano State. We also gave 40 face shields to College of Medicine of the University of Lagos, as well as 50 N95 nose masks. And we are receiving feedback, which is helping us understand how to do production better. Other COVID-related work that we are doing is this teleoperative lung ultrasound to diagnose and triage patients diagnosed with COVID-19 at the National Hospital. In the same vein, we have received internal review approval, and we are waiting for National Hospital to get us that same approval. The cost of this and the ability for it to support the point of care testing is what is most exciting about the work on teleoperative lung ultrasound. We are also involved in design and testing of emergency use respirators in hospitals. And this is another engineering opportunity that the university is providing to healthcare industry. We were able to receive, based on the feedback from doctors, some anecdotal evidence of need for degradation of some of these personal protective equipment. For example, in National Hospital, we were told that at the beginning of the pandemic, 2,500 workers needed to get face shields or face masks. And these face masks were discarded on a daily basis. If they had reusable face masks, they would not have had the huge armada of materials that needed to be incinerated and handled after this. So we are currently looking at other opportunities. So what next? We are trying to scale up the production of the PPEs to achieve local capacity to meet emerging demands. And we're also looking at research to develop point-of-care testing, in developing rapid diagnostic kits based on nucleic acid, such as loop-amplified nucleic acid tests, and aptamers that have been connected devices that improve the visualization so that we can use it as point-of-care test and rapid diagnostic. We also have aspirational plans to multiply and distribute animal models such as the HSC2 receptor-bearing mice for COVID-related research, something that would improve things a lot. In summary, I believe that the relationship between AUST and WPI has led to better understanding of the role that university could play within the gamut of an emergency situation that we have today. And we are also thankful for the efforts of BVGH, who have also come to assist us in increasing our outreach to hospitals and linking us to places where we get support. So thank you very much. This is the end of my presentation, and I'm grateful for everybody that has assisted to getting this opportunity to us. And I thank the students and faculty who joined us to make these PPEs available to hospitals and continuously work to ensure that we have a role to play in this pandemic. Thank you very much.
Good morning, good afternoon, and good evening, everyone. My name is Magda Schoeneich, and I'm the head of Center for Scientific Leadership and Innovation at Takeda Pharmaceuticals. And I have a great pleasure to talk to you today about our efforts and tries and vision for how we plan to ignite innovation across the health ecosystems around the world, including the Africa. A quick disclaimer that the views in this presentation are mine. They represent what we are doing, but they not necessarily reflect all the views or opinions of my employer. And I want to start with a very important slide that really tells what's our vision for innovation. It's all about addressing the consequences of things that hasn't yet happened. So we think of innovation as of not only the next big thing. It's not only the AI or the most closed events that we have to address, but it's really looking to the future and thinking, what will decisions that we make today, what would they mean to the world? We know that by 2035, the demographic of our world would be extremely different. We will see 1/3 of population being in Africa and Middle East continent. And if we want to be successful in innovating, we believe that we really have to think, what does it mean to everything we do today? How do we have to prepare the world for tomorrow? And to make sure that whatever we do, whichever innovation we bring, technological, organizational, medical, is preparing us and preparing the world for the few new realities. Our vision as the center is to really accelerate development of high impact solution for those we have the privilege to serve. And that's predominantly our patients. But we're also serving as a piece of organization, our communities, our partners, people who are working for Takeda and for other industries. And we want to make sure that the way they move forward, the way they innovate, the way you innovate is truly sustainable. And as we look at this, we want to make sure that we do it by bringing and identifying lots of diverse perspectives developing capabilities that maybe today are not necessarily the one that would come to the top of head, and also that we partner effectively. My previous career was in professional dancing, so obviously we went into art, and we spent lots of time talking to people who are living in the art industry, asking how do they communicate, what's coming their way. Many artists that we actually interacted with came from Africa. I got the chance to meet some amazing artists from Tanzania and from Zimbabwe in this journey, and also learn from them. We learn from patients, we learn from healthcare systems. We also went on the other end of the spectrum. We spoke to other leaders in pharma. We spoke to academicians, people who write for really cool Hollywood shows like Mr. Robot or Westworld, and really try to envision what the future will be, how we as humans will have to work. Now, what you see on this screen are 4 core principles that our organization, Takeda, has embedded in the way of working and really committed ourselves to growing and making sure that as we bring medicines to the patients, we always think about the ways of working that are full of creative energy, that we never stop being focused on the target and we never give up, that we always want to deliver together with our partners. Collaborative network, which means a lot about building trustful connections, which means that sometimes it is about partnering with people who may have a very different industry in which they work, that they have very different background, but yet we are able to define common goal, common rules and principles of behavior, and that together we reach the common goals, and then we know what to do with it. And then if we take it to the next level, we talk about collective intelligence. So how do you bring collaboration and now overlap it with artificial intelligence, for instance? With great partnership, I will touch on this with MIT here in Boston and Center for Collective Intelligence. And the last one, very important one, is focus curiosity. Focus curiosity, never stopping asking, how may we fix this problem? How may we really understand the patient and person that's at the end of this conversation? It's a combination of design thinking, it's a combination of system thinking, and it's also a combination of tangible innovation that we got the privilege to work with our colleagues at Harvard on. So bring it all together is what CSLI do. Now we embarked on this really selective intelligence, and collaborations are happening already, and they are happening all over the world. And in Takeda specifically, they are happening a lot in Africa. We're not just doing something, designing it with Ivy Towers in Boston and parachuting it to Africa. That would be absolutely wrong. We want to build future together with people who ultimately are at the receiving end on it. And that's a great way, an only way probably to actually achieve our goals. Now, as I said before, the way we work today and the way we think of innovation today, the way we think about collaborations today, likely will not be the same in the future. So part of being acute to this change, part of being organization, partners and community that does it appropriately and that does apply collective intelligence, that does apply collaborative network and focus curiosity to everything we do, is trying to imagine this new model of collaboration. And this is what we've been doing for the past year, and that's also what we hope to bring forward in this upcoming months, even more closely to you, to the audiences here. And this is a bit of a story. As a company that's trying to learn, sometimes we also have to balance it with the fact that as an industry, and specifically as Takeda, we've been around for over 200 years, 237. That's a long time. And there's a long time that we've been doing things certain ways. So when we are asked to do something different, it's not always easy. Earlier this year, I got a chance to talk to my friend Freddy, Nguyen, who I believe is also on this panel. And Freddy called me, or I called Freddy and said, you're doing this hackathon thing about the COVID. And it was just when COVID was starting. And I asked him, how could we help? And frankly, I didn't know. The very natural thing was to offer bringing some money and maybe sponsoring the conference. But when Freddy and I talked, he said, you know what would be most important is if you can get your guys and your organization to share the knowledge, because we are entering the field where we have lots of passionate people, lots of young people, the hackers community from all over the world. One of them was the hackathons was very specific to Africa. And they have ideas, they know what the problems are. But COVID is different, healthcare is different. You need some understanding of regulation, you need some understanding of this much hardcore science and data and everything that comes with it. Do you think your teams would be willing to just share the knowledge? And I went back and I thought, wow, we we definitely should do it, but do we have enough passion in the organization? Do we have actually understanding what hacking means? So we posted it online and within an internal group, and we basically asked, hey, MIT is running the hackathon. We will teach you how to use Slack and Teams, which were the platform they were using. Would you be willing to partner up with them? It was truly cool that at the first hackathon, we have 30 people from Takeda that came over the 1 or 2 days, join us and said, we want to learn, work the entire weekend, over 40 hours with all the 15,000+ hackers. And together, by bringing the knowledge of our people, by passion and understanding of the problem, of people who are facing lack of PPEs on the ground, of people who are trying to understand how to explain COVID to their grandma, or everything and anything, came together, worked together, and over these 48 hours, they arrived at solution. They are now actually moving towards being market product, being things that are really in the real world and helping people. So we suddenly realized that we have opportunity to share our knowledge. We have the opportunity and ability, in fact, to kind of prototype. And what if then we can also support it financially? What could we do together? So this is still a very conceptual work for us. This evolved over the time of COVID. But if you think of the number of people behind it, it's truly inspiring and truly amazing. We have done so much together already. I think there's so much more to be done, but it takes the courage to do it differently. And this talk, I want to encourage you to try to do it differently, to try to do a first draft, and to close this journey of discovery of what and how to do. I want to play one video of a team that done exactly this. This team was asked to rethink how to address needs of patients and present a new drug delivery device. And we asked them to do it very differently, to work with people they never worked with, to do things that never thought have any relevance. And they succeeded. But the most important message from them, as you will see here, was take the first step. And I hope that we all can use the opportunity here together to start with our first draft.